we have to understand that different demographics are going to have unique needs, and radiology has to do a better job with really rebranding itself to those groups, right? For Black medical students and minority medical students, they tend to have more emphasis on giving back to their communities, right? Well, how are you going to do that sitting behind a desk reading scans all day, right? So rebranding and emphasizing that radiologists actually do tremendous work with population health, right? You may not have meaningful interactions with patients on a daily basis, but when it comes to breast cancer screening, lung cancer screening, we're seeing radiologists play a really significant role in guidelines, in community outreach. Something that we're doing here at Penn is trying to have more emphasis on community outreach and get people from underserved communities more accessible to the resources, to the screening resources. So we have to really understand each group sort of has its own different needs, that many medical students lack exposure, that many medical students also have misconceptions about radiology, and the diversity of radiology in terms of the workforce, right? Like, you don't just have to sit behind a computer screen all day and dictate yourself to death, right? You can actually do interventional radiology, interact with patients constantly on an inpatient and even outpatient basis. You can do breast imaging where you're actually doing the ultrasound, talking to the patient, providing comfort, empathy, giving difficult talks and difficult conversations when it comes to conveying the diagnosis of breast cancer, right? And then the procedural aspect of doing the biopsies. You're seeing some procedural aspects in musculoskeletal radiology when it comes to chronic pain management. So all of these things should be incorporated into the message, the brand of radiology. And I think if you do that, that more people from these underrepresented groups will be receptive to a career in radiology.
Yeah. Hey guys, and welcome back to another episode of Clinically Correlate with Azfar and Vedant, episode 9. And today we have our very good friend, Damien Medrano, who has a very, very interesting background prior to pursuing his career in medicine. So he was an actor, and I won't spoil it, but he did appear on a very popular TV show.
You may have heard of it.
You may have heard of it. It's called Grey's Anatomy. But more importantly, we do jump into a very important initiative that Damien is championing, not just in diagnostic radiology, but within the general medical community. And he shares his ideas of how we can make radiology a more diverse and equitable specialty. So stay tuned and enjoy. All right, Damien. So the way we start off all our interviews with a new guest is, reimagine yourself back to those days when you're interviewing for residency, right? The most common question you got asked was, tell me about yourself. And that's exactly where you're going to be answering now. So Damien, tell us a little bit about yourself.
Yeah, sure. So I'm one of the few West Coasters, it seems like, at Penn. I grew up in Los Angeles, and I was there pretty much all the way up until undergrad. I went to Loyola Marymount University, where I majored in biology and minored in theater. And after graduating, I did a little bit of acting in LA. I was kind of on the fence about medicine, but knew I really liked acting. So I continued pursuing that and was even on a few episodes of Grey's Anatomy as an extra, wow, which is a pretty cool experience. But ultimately, I decided medicine was the way to go for me. And I went to graduate school at Drexel University. And then shortly after that, I went to University of Nevada, Las Vegas for medical school. And my wife and I both got in there. It was the only program that we both got into for medical school, and it worked out beautifully. They gave the first class, which I was part of, full ride scholarships, so we saved a lot of money by going there. And we were looking at programs for residency, and because we had both went to Drexel for graduate school, we knew Philly was a familiar area. We knew what we're getting ourselves into. And man, I wish the weather was as good as LA. Unfortunately, it's not.
I wish the same.
Yeah, but yeah, we knew what we were getting ourselves into. So Penn was a program that really stood out, had a lot to offer for both of us. I was applying radiology, she was applying anesthesiology. And we interviewed at a lot of programs because it was virtual, and it was a new format with the virtual interviews because of the COVID pandemic. But ultimately, we were both very happy with our choice, and couples matched at Penn.
Nice. It's very interesting because you're from Miami and you're from LA. You went to medical school in Las Vegas, and I went to medical school in upstate New York. And I'm the only person who can tell my wife, "Hey, honey, look, the Philly weather is actually better."
Yeah.
But I love how you kind of glossed over, like, "Oh yeah, I was in acting a little bit," which is super cool, right? That's insane. So tell us about that experience. I see you minored in theater, right? Mm-hmm. And you got into a few episodes of Grey's Anatomy. So how many months, years did you give acting a shot?
So I actually always kind of had an interest in acting from a very young child. I kind of wanted to be like Will Smith in Fresh Prince of Bel-Air, and I always had it in the back of my head. But in undergrad, I was more focused on pre-med, right? And pre-meds are just like focused on one thing.
Yep.
It wasn't until maybe the end of sophomore year that I realized that it might be beneficial to get more experience outside of the sciences, and specifically acting was something that I thought could be definitely help with the patient-provider interaction. So I sort of just stumbled into it. I took a class, really liked it, and then shortly after that, taking that first class, I declared myself a theater minor and was doing, every semester I was doing at least one acting course at Loyola Marymount University. And I really enjoyed it. It was a great stress reliever from the constant just reading insane amount of textbooks and the science and the academic rigor that many pre-meds have to go through. So it was a good way to kind of escape and kind of challenge myself in new ways. Definitely helped with the communication skills, and that was something that I thought or something that I noticed almost right away when I started medical school, that the benefit of having that background in acting when it comes to talking with patients, being able to express empathy, it worked pretty seamlessly. But at first it was kind of like, I don't know, should I really pursue this? Because in LA, it's like one out of every 4 people are acting, and it takes a long time to really break through in that industry. We're talking like 7 years of work before a lot of people get that first big gig that makes them a breakout star. So I was like, okay, 7 years, I could just do medical school. I could be a doctor in the same amount of time,
right.
And still do acting later if I wanted to.
Yeah.
So is that something you still plan on doing, like keeping your acting career ongoing? Yeah,
I think I definitely want to keep the door open. I couldn't tell you specifically what I would want to do with that, but if Grey's Anatomy, if they want to give me a call again, I can be back on the show as a real doctor.
There you go. Yeah.
But I think it's always good to have something on the side of your main professional career. And nowadays, everyone sort of has an easy way to get access to online platforms and things like that. So we'll see. Maybe in the next few months or years, I'll start to come up with something. But I think right now, focus mainly on medicine. With a lot of the things that I'm doing in mentorship may kind of overlap with some of the things that I'm thinking about for social media and If you guys are listening to this, definitely give me a follow on Twitter at Damien Medrano 1 and Instagram Damien_med if you want kind of like a inside look at the life of a radiologist.
Yeah, well, I think that you're one of the few people, are the only person who has an active like Twitter presence and like an active social media presence that is public, I want to say, which is interesting and cool and on par with acting or like actors, right?
Yeah.
But like, I think you brought up some very, very critical points. The fact that learning to act and learning to kind of put yourself in the shoes of a person where you may not naturally feel that way is super important, right? It's always important to express empathy, even regardless of what you're feeling, right? We're all humans. We go through all of the emotions, but sort of couching that and being empathetic with the patient when we are in the patient room is super, super critical. And that is an excellent point that you brought up, a real life skill that you honed while you're acting, right? It's also interesting when you mentioned that those are the acting doors. You haven't completely closed them. You're keeping them open, sort of for the future. This brings in mind for me when I was in undergrad, I had this. We had to take like an art class to meet a requirement. I took like a drama class, right, in my like final year of undergrad, and so there was this teacher, and she had a good friend who would come in frequently to kind of coach us through a lot of things, but interestingly, she was a retired lawyer. And so she made her money, made her career, kids were out of the home. And so she was like, you know what, I'm going to act now. And she had the time, and more importantly, she had, I guess, the financial freedom to pursue that. And it's so cool, like kind of thinking back, one of the things that she said was, even if when you're passionate about one career, when you go through life, that may pivot. So always have like skills that where you can pivot to. And so similarly, I think I'm recalling she may have been like an acting minor or like a double major in like theater as well, something like that. So that's very interesting and that's very cool, man. And something that you'll probably look back to. You brought up Grey's Anatomy, which is also interesting because so often in these medical shows, we see them like pointing to the liver and they're like, oh yeah, that's the kid. Like, no, it's not. So if you ever get on Grey's Anatomy, we'll hold you to the accuracy of the radiology, at least the radiologic images, right? Like they're pointing to the right stuff. They're not mixing up left and right.
It's like on Scrubs where the chest x-rays backwards on like the main title screen.
Yeah, well, joke's on you, though. Side is inverse.
Nice. Yeah, I mean, the thought of even having a radiologist as a main character would be interesting for Grey's Anatomy. It'd probably have to be an IR doctor, someone who, gets their hands a little bit dirtier.
I don't know. If they can do Brooklyn Nine-Nine all based off of like a police department, they can just do it in the DR reading room. And the drama that happens every time the ED calls.
Just like you're not even in scrubs, you're just wearing a shirt and khakis, walking to the reading room 9 a.m. with a coffee in hand. Sitting down, chatting, no, but I think it's a really, really cool and unique sort of achievement and skill that you have that I don't think we'll probably encounter in the next few years, unless we get those 1 in 4 people who are also in LA like into our program, right? But yeah, I think if you wouldn't mind, I wanted to delve a little bit more into that as well. Did you like act in like plays during undergrad, and like besides Grey's Anatomy, like what else have you sort of dabbled into, or where else can we see you?
Well, if you want to see the CV, all you had to do is ask. So yeah, back to undergrad, right? So I'm a theater minor. I'm doing these courses. Really, I mean, that's pretty straightforward, right? You just show up, you do the courses, you're in and out. I had a few opportunities, though, outside of that to do some of the plays, some of the performances, things that people from the film department were doing and things that the theater department were doing. So I think my junior year, I was part of a play called The Colored Museum and had about maybe an 8-minute monologue playing a soldier who was actually dead and came back to life.
Wow.
And yeah, it's a pretty fascinating thing, piece of work that really highlights some of the perspective from the Black community. I think the peak of my theater in undergrad was when I was part of a two-man play, Top Dog Underdog, and just me and another actor on stage for, we're talking maybe 2.5 hours.
Wow.
Having to memorize 100 and some pages of script. It was, I was so nervous. Like when you go out there in front of, a whole crowd of people, many of which you can't see because of the lighting. You just sort of like see vague faces. It was a lot of adrenaline for sure, and palpitations.
Yeah.
But that's part of the magic of acting. I think is you overcome a lot of that, and I'm sure we all have felt that, right? Public speaking anxiety, it's a real thing. And whether you're doing it in undergrad, presenting a poster, or doing something as big as a play, we all have some of those that experience, and you learn how to overcome those things. And so for me, it was actually more meditation before these performances, really having a control of my breathing. Yeah, it was probably one of my biggest accomplishments is doing that play. And I was really happy to have the opportunity, which was offered really because there weren't a lot of Black students who were in theater at Loyola Marymount. So they had this idea of doing the play, but they were like, okay, there's not like a lot of people here who would be able to play the characters. So they reached out to me, and I just kind of went for it. There's a lot of doors in life that will open just because, and sometimes I think you just have to go out on a limb and take those opportunities and try and make the most out of them, whatever they may be. If you fail, that becomes a great teaching lesson and gives you opportunity to grow as a person in whatever way that you think that'll happen. But I said yes a lot, and kind of a lot of good things happened. And then after graduating from LMU, I was out there just going on auditions and trying to make it as big as possible in as little time as possible, because I was pretty sure that if acting wasn't going to work out, then I was going to do medicine, something in the medical field. And I didn't want to really delay, multiple years of trying to do it as an actor and then finding out, okay, let's do medicine. And I'm already like early 30s when I'm like pursuing that. So I had a very short time frame, basically gave it like about 12 months after graduating to see what happens with acting, with my acting career, and did some interesting plays. Most of them were like student projects, so low budget things. Maybe a couple things that ended up being on like Netflix, but to be honest, that is so far on the back burner now. I couldn't even tell you half of them. I think the last thing that I actually did in acting was The Witch's Gauntlet, which was done here in Philadelphia when I was here for graduate school, and I played one of the characters who got killed. Yeah, it was a great opportunity, great learning experience for me when it comes to that, and I feel like it made me better as a doctor.
Oh man, like memorizing 100 pages of lines. That sounds crazy.
Sounds worse than step one.
Way
Like
worse.
step one must have been a breeze, right? Like,
Yeah, no, that's amazing, man. You're way too humble. And I'm gonna tell you that right now. How did you gloss over that accomplishment?
I mean, it's the first time like I think either one of us is actually hearing the full story. Which is really awesome.
Yeah, because we've always heard about the surface. Yeah, you're an actor, you're in Grey's Anatomy, but we never really delved beyond that, right? And it's so refreshing to hear, like, all the nitty gritty details. I'm sure there's more that we can fish out, but
yeah, there's a few headshots. Maybe I'll be posting on my social media one day. Yeah.
Nice.
So I always like have a question for people either outside of medicine or have had like a prior career before going to medicine, because for a lot of people who, if healthcare and medicine is the only thing they've done, you kind of get tunnel vision, right? Like this is the only perspective you have and the only challenges you've seen. Coming from your background, what is like kind of insights that you have of saying, here are the things that medicine or healthcare does good. Here are the things that it can improve upon based off of your other experiences.
I think any career has that potential to give someone tunnel vision, right? And for me, I always valued trying to get as many different experiences in life as I can, that the volume of different experiences has real value in the person that you end up becoming. And so for me, it actually, there's always hesitation when you are trying to do multiple things, right? And definitely trying to have a medical career requires so much time, energy, and money that it feels like a gamble trying to do these other things. But I've always sort of embraced it, and starting, I guess, in college, just the fulfillment of being able to gain these other skills, and explore these other pursuits that I was generally interested in, and wanted to know what I could do with. So that has always been valuable to me. I think, I'm not really sure. I think anyone who's thinking about applying to medical school or in medical school now, they should really try and take away that sense of exploring other things, because the medical field, as appealing as it may seem at first, when you're at this point of your stage of training, you've already realized the negative aspects of medicine when it comes to just terrible work-life balance and higher prevalence of depression, substance abuse among physicians. And physicians who are married tend to have a higher divorce rate, right? So there's all these things that you have to acknowledge, and it sort of comes with the trade-off of you get to be a physician and sort of at the top of in some people's eyes society in terms of professional accomplishments, but the trade-off is something that is real for a lot of people, something that people struggle with. Even on a daily basis. So you just have to know, medicine isn't all, great moments and, good smelling roses, as our program director likes to say a lot, take a walk and smell the roses. There's a lot of things in medicine that can be very toxic. So these things that I've personally been doing, not just acting, because acting is, it comes and goes, right? But playing guitar a lot, exercising a lot, trying to have a more holistic approach to life than just focusing on one aspect to excel in, I think is something that should be fundamental to a lot of people in medicine. Because there's definitely a lot of protective aspects when it comes to investing in your wellness and making sure that you take the time for self-care.
What you said about, I think, acquiring multiple skills and being a more holistic person, right? Medicine is very romanticized, especially in TV, right? Grey's Anatomy. I watched House a lot, extremely romanticized. And all these the new TV shows about new interns, so Geniuses, right? Chicago Med. On all these shows, the doctors, the nurses, the healthcare workers are quote unquote heroes. In fact, we were called heroes during the COVID-19 pandemic, right? And I think with this romanticized view, most of the folks who don't have parents or direct relatives in medicine sort of suffer through most of the abuses, meaning these are all surprising to us, right? Now, if you have a parent, a close relative, sibling in medicine. They'll kind of tell you and prepare you and coach you to go through it. But this is like a real trauma that I feel like a lot of folks who are pursuing medicine or pursuing the healthcare field don't take into account. And the other problem is, these are young folks, people in their 20s. You're asking them to make a decision. Yes, their medical training is prolonged, but you need a certain level of maturity to sort of ask these questions, because when we are young, we feel invincible, right? Dude, I could tell you, I could like lay on the floor, sleep, wake up the next day, go to class, no problems, right? Now, if my bed doesn't have a certain level of softness, I'm waking up with back pain. Right? And that's basically just a metaphor to not just like, the physical decay, but like the mental, I don't want to say decay, but like the fortitude that young folks think that they have, right? Mm-hmm. And it's so super critical what you brought up, like wellness. I don't know how many young folks think about wellness. I feel like, at least for me, when I was young, and this is getting a little philosophical, but like things that I did was to, in some ways, either garner more respect, be in a certain social group, but it was never because, hey, I'm doing this because it's better for me and my future and my well-being, right? That level of mindset, at least for me, was sort of like never there or never coached to me. I was also an immigrant, maybe some of the challenges were ingrained in that as well, right? Mm-hmm. But as you said, man, it's tough. It's really tough. Every stage has a challenge. The rat race never ends. And I think the rat race never ends in all careers. It's just we grow up and we mature into realizing it, and we sort of accept it in a way.
I think especially, in medicine, in TV, people, no matter where you live, they have an idea of who their doctor is, right? It's probably the most visible white-collar job across the world, because, you may have some relative that is a banker, but like an investment banker, but like there's no real way that like someone in like, like in the countryside in Florida is going to know investment banker, but they'll know their doctor. And I think, especially with like the TV shows that you're talking about, like it creates this narrative, and obviously I think it piques people's interest from that perspective. But, I think what we all know is, it's almost like a needle in a haystack, right? Like maybe every now and then there's something super exciting, and like that's what we all have case conference for. We talk about it. It's a cool case, and definitely from like the clinical and science like standpoint, it definitely piques your interest. But at the end of the day, like here's a task, you do it, and like the reason modern medicine has improved so much is because we keep doing those things very, very well. There's definitely areas we can improve on, but like the stuff that we know, we do them very well. But at the same time, there comes the challenges with that. There's the fact that medicine itself is 24/7. Like if you're in the hospital setting, and then there's definitely the tracks in different fields that it can be in the outpatient setting, but even those things can be stressful in their own way. So I totally agree with you. It's like maybe I guess when you're younger, it's also you're looking at the goal, right? And it's like here are the next steps I need to do, like shadowing, research, but then actually understanding like what that role is, and then what that role is for like 30 years. Because like once you're in there, your job may not change that much, right? Good or bad for physicians. So it's like you said, it's asking a 20-year-old to make a 30-year-long decision with incomplete information. It's a tough thing to do.
Yeah, there's a lot of gaps for sure, and a lot of inaccuracies as we now see on TV, right? As we
That's right.
gotten older.
Not everyone has lupus.
And even if you give them complete information, I don't know how much they'll value it, right? They'll still have that, I'm going to go for it attitude, and think, we can sort of maintain that vigor for like 30 plus years, but we can't. And our priorities change too, right? That's the other thing. Like you don't have a family when you're 20-year-old. Most 20-year-olds don't, right? But then, you grow up, you have families, you have kids, you have other responsibilities, right? And that sort of start creeping in. But I think one of the other important things that you mentioned, or one of the other important things that you're trying to champion is actually diversity and equity in medicine. Now, before we get into the medicine part of it, you sort of mentioned that, when you were doing these plays in your undergraduate institution, there were not a lot of black students in theater. Now, was it specifically in theater minor, or was it like university-wide phenomena?
Well, I think there's not a lot of black students, period, in higher education. I was fortunate enough to attend a great undergrad university where they at least had better numbers than some of the other schools. But it's a combination of there's already a limited number on campus, right? And then you look at different departments, and there's definitely going to be a discrepancy there, and just not a lot of interest for people to pursue careers in theater and theater arts when it came to the black students on campus. And so the numbers weren't there. And very similarly, I guess, in radiology, the numbers aren't there. There's a lot of that feeling of being one of the few black faces in the room, pretty much for much of my academic life, going all the way back to middle school even. It's at every level. Black people are underrepresented, at least in the community that I was raised in. So it's definitely something that is important to me, and I think something that I'm trying to really flip the switch on, and trying to get my face out there and show people that medicine is working on diversity, and that if you're interested, actually be interested in it, and know that there's people that look like a lot of different people in the country. So, very easily people can be dissuaded by something that may seem as minimal as representation, but I'm sure we can all kind of reflect on instances where we thought, maybe I can't do that because I don't see people who look like me or share the same values or share the same culture as I do. And that could be a huge hindrance, and definitely something that I recall when I was looking at medical school, not seeing a lot of minority populations in medical school at the physician level. And there needs to be kind of a counter effort to help keep that door open. Otherwise, people aren't ever going to really appreciate or realize that being a physician is, in fact, something that they can achieve in this country.
Yeah, I think that something that directly flows with that, as you said, is a mentorship, right? Because when you don't have folks who look like you, it's difficult to, first of all, it's discouraging. Mm-hmm. And also it's difficult to find especially when you don't share the same culture, difficult to find mentors, right? Folks where, when you describe your own struggles, they may have sort of a similar understanding or have an approach that is concordant with your cultural beliefs and your own values, right? And this is a universal phenomenon, right? It's in every single field. It's not just an American problem. It's not just a Western problem. It's a worldwide problem, man. I feel like it's grossly undervalued across the world. And so I guess my question would be to you is, how did you seek mentorship? Like, how did you get into, you were interested in medicine, right? How did you sort of forge a path forward into medicine? How did you seek out your post-bac programs? Who did you take advice from?
Mm-hmm. So for me, and probably for a lot of people, it's going to be a number of factors that really influence the choices that we make when it comes to, in this instance, career choices. And for me, I'm the first doctor in my family. I didn't really have anyone in my family who had taken that path. And so a lot of the information that I had to rely on was through interacting with other people, friends who had doctors in their families, being able to connect with them through that, and advisors in undergrad. That's sort of the kind of where I got the idea that I could do medicine, at least some of the influence. As far as mentorship goes, right? Mentorship's super important. and I couldn't really identify any mentors, but I think the few people like my advisor sort of served as a mentor to at least help me get my foot in the door, right? And for me, variable experiences with mentors, reaching out to people where some mentors are more encouraging and more optimistic, other mentors are not so much. So you really have to go out and talk to multiple people. You can't rely on one mentor to really solve all your problems or give you advice that's going to work out 10 times out of 10. So I talked to multiple people about medicine, and I remember one. I was interested in neurology because I'd actually seen a neurologist as a pediatric patient when I was 13, 14 years old. I had a couple syncope episodes and saw a neurologist for being evaluated for maybe like a epilepsy. So I always had a good interaction with my neurologist, and I always thought, okay, neurology. And I reached out to this neurosurgeon nearby when I'm in undergrad to kind of pick his brain about his career. I want to figure out how long did it take for him to be a neurosurgeon. This is here in Southern California. And just was not encouraging at all. He basically talked to me and said, at best, maybe you could get into one of those like international medical schools, but probably not going to work out. So, look at other things, which is not something that you want to hear.
Yeah.
You can imagine being, a 22-year-old,
Yeah.
and you're all dressed up, and you're looking forward to this great interaction, and it doesn't work out that way. So, not a lot of mentors that I could identify. It wasn't until actually probably medical school when I was able to identify some mentors, and I gravitated towards a couple black physicians at my medical school, one in pediatrics, one in surgical oncology. And they both were actually very involved when they were in medical school with DEI initiatives, being involved with SNMA, Student National Medical Association, which represents the black students, medical students. And so I sort of took their advice a lot and was involved in SNMA as well, and then also involved in Latino Medical Student Association. So I sort of found my way gravitating towards people who were going to help lift me up and make me feel good and make me really understand that, for me as a black male, I'm probably one of the more underrepresented individuals or underrepresented groups in medicine, because there's not a lot of black people in medicine. And then you look at admissions, and black men are probably admitted at the lowest rate compared to other demographics. So, people who were able to be receptive to that and encourage me, give me opportunities. I was all ears, and I think you have to be proactive. That's probably the biggest takeaway: is be proactive, approach multiple mentors, and take on multiple opportunities. Some of them will stick. You're not going to hear good news from everybody, so don't expect that things are going to happen just as you would want them to. But eventually, you'll sort of funnel down to a few strong people who are going to take the time to invest in you and make sure that you get the most in your path to a fulfilling career.
That's such a great point, right? Because you don't need everyone to vouch for you, right? You just need a few people who really know you, really care about you, in that way, and really vouch for you. And I'm sure all of us in different ways. It's just a handful of people at all those stages that, if they believe in you, they give you opportunities, you excel in them. Like, it goes a long, long way. Mm-hmm. And to your point of overall just race in medicine, right? It's not just the representation, from a clinical standpoint, but that kind of blends over to the actual patient care too. Kind of in researching before our interview here, even within radiology, looks like, I was reading like a paper they were looking back to when x-rays were becoming like first used, and, they had the assumption that, you needed a higher amount of radiation dose with darker skin for penetration, which now we know is not accurate at all. But, it's one of those things that without representation, I think, across the board and people having different voices and making sure that that's all heard, you can have kind of very skewed evaluation of whatever data you're looking at and making these conclusions that ultimately do harm people by, in this case, significantly increasing their radiation exposure.
Yeah, that was, our history is kind of riddled with examples like that. And for Black people in particular, we have to understand that the context in which our nation was founded really had Black people at the bottom of society, right? And when you're at the bottom, you're going to have the people on top have negative views, and that's where you see a lot of the stereotypes, misconceptions about Black people. So this goes way back to the founding of this country, and even before that, with European nations as they were exploring other continents and explored Africa, having negative views about Africans. As far as medicine and race, you bring up a great example where you have this belief that Black people have denser bones, that their skin is thicker, and that has to be compensated by increasing the dose, your radiation dose for x-rays, and seeing that it is something that was ingrained in the culture of medicine in different parts of the country, something that was integrated into the texts of manufacturers, into the academic scientific literature, really pervasive ideas about Black people, and that's just one example, right? So the important thing to really take note there, I mentioned the historical kind of context in which we have to understand these things, but also we have to appreciate that the intent wasn't really to harm Black patients, right? By increasing the radiation dose, the idea was to compensate based off these false beliefs, but with the intention to really maximize the positive outcomes, therapeutic outcomes for the patients. So a lot of the examples that we see in medicine with the Tuskegee experiments, experiments with syphilis in Guatemala, to some degree, there's going to be a level of good intent, but of course, there's going to be examples where it was just malpractice, basically, and malicious intent at times. But I think you have to kind of look at things from different perspectives, right? Because intent, we actually do put some value on that. And I think, going forward, we have to kind of understand that, your good intentions don't always result in good things and good outcomes for patients. The important thing is really asking the right questions, right? Like, why did we have these beliefs, right? And that goes back to the misconceptions of a group of people, a racial group of people. And I think one of the biggest things that I've learned so far in medical school and now in residency training is race as a social construct, and how it has often been confused as a biological concept. The idea that races are biologically distinct, and there's plenty of evidence now that really shows how false that is, and that 99% of our DNA is basically the same, that we share way more genetically, and that there's probably more diversity within racial groups than between racial groups. So a lot of science has kind of helped kind of shed light on that, but there's still going to be issues of what people call scientific racism, where the idea that races are biologically distinct groups, and that's going to have many implications when it comes to clinical practice. And we see this with in cardiology, with prescribing certain medications for Black patients and only Black patients. Breast cancer screening is a big deal, right? And for there are certain calculators that can help predict the risk for individual patients, about their risk. And some of the calculators actually incorporate race, ethnicity into the equation. And when you think of race as a biological construct, that works very well, right? You have distinct, genetically unique individuals of a certain race. Give them a calculator that works for them, that accurately predicts the risk of breast cancer for their respective race and ethnic group, right? I get it. Well-intentioned. However, I think it brings in a lot of gray area, right, when it comes to multiracial people like myself.
Yeah.
Which box do you check off, right?
Right.
When you only have one option to check off a racial ethnic group. But then even beyond that, we have people coming from all over the world to the United States, some of which were born in other countries and were brought over at very young ages. So how do you think of ethnicity in that context when someone may have only spent a few months, maybe a few years in that country of origin, and now you're incorporating that into a calculator to kind of predict their genetic risk when they may not actually identify with that culture anymore. So all of this is self-reported stuff, right? So it all comes down to how patients feel, which opens up another gray area because of the perceptions of certain races and sort of the hierarchy, almost like caste-like system when it comes to race, ethnicity. Some people are going to be uncomfortable identifying with, what's seen as like a lower tier category, right? And so they may actually try and, convince themselves, okay, I'm not going to mark that on the box because of the negative perception of it, right? So, self-identifying racial, ethnic things, categories, I think, have a lot of loopholes that these calculators don't take into account.
In Journal Club for like the interventional residents, we were going over, peripheral arterial disease treatment. And I don't know if you've looked at, have you seen those maps before of amputation rates and states in the U.S.?
Yeah.
You wouldn't know if it's amputation rates or the Civil War because it's almost like a one-to-one kind of correlation of almost like the Mason-Dixon line, honestly, coming across. And then, and it's, amputation rates, and the subset of that is, how many of those can get endovascular treatment. And, part of that is like endovascular treatment, the cost associated with it much higher for like one treatment, and then two, it's more of a planned situation because you kind of need to be worked up versus an amputation. If you don't get treatment, is the emergent surgery, and sure, it's a definitive for that problem. Obviously, it has other kind of downstream risks associated with it, and they could kind of adjust. It was a Medicare study, so they try to adjust for race and age, obviously. But one component that I brought up was, there still was a significant difference, I think, with race in that study, and the question was, but it's all Medicare patients, but you don't know to what extent those patients had like access to health insurance before they were Medicare eligible, and versus other folks as well. So it's even in these studies that when it's controlled and it's like, oh, everything's the same. There's a lot of, like you said, the social determinants of health associated with it, and how much of that is really tied into race. And it's a very complex thing, and I think like the toughest part about medicine, actually the scariest and toughest part is, we're taking all these statistical models and data and we're putting into categorical variables, right? Of like, you have a higher risk, you have a lower risk. Even as us as physicians, like, unless we go really into the data, we can start teasing out that stuff. But as a medical student, you're just like, oh, that these few things increases your risk, these few things increase or decrease your risk. And that's kind of where wrong data and wrong categorical labels kind of just propagate over the years as well. And
yeah,
so even if you didn't know you had the best of intentions, it's like, to over time to kind of self-examine to see where those things that you considered fundamental, where that data actually came from.
We see this all the time. And if we go back to when we were medical students, right? Mm-hmm. Medical education, we see race and ethnicity inappropriately used for for multiple choice questions. We see race and ethnicity inappropriately used for testing purposes, for if you're going over a journal, if you're rounding on patients in the hospital. And how many times did we see the question about the Black patient history of sickle cell disease, right, on a question stem, and how quickly we associate those two things as being sort of innately connected, right?
Yeah.
There's a biological connection there, when really the pattern of sickle cell has more to do with the trends, or not the trends, with the geographic distribution of malaria disease and how that plays into a factor, right? But none of that is really explained in medical school, or at least explained very, very poorly. You see race used as risk factors, but without any mention of social determinants of health and how that plays a huge role in patient care. Up to 80% of an individual's health is determined by these social determinants of health. Mm-hmm. And on top of that, you have provider bias, right? Where there has been plenty of studies that have shown biases when it comes to pain management in the ED setting, with Black patients getting less appropriate pain medication for their pain when presented at the same level as their white counterparts. We see this plenty of examples like that. So what do we do about this, right? Well, I think medical education they're trying to do a better job with this and really highlight those things, right? Race, ethnicity are sort of they're better proxies for someone's socioeconomic status, and to kind of introduce concepts of social determinants of health, right? That's how, that's the connection, right? And it has less to do with the biological component, which has been proven to be false. When we look at radiology, let's just kind of look at the problem, look at the numbers, and kind of think about solutions. What's helpful, what's not helpful. Right? So radiology, when it comes to female representation, very underrepresented. There was a study a few years ago that looked at female representation, and radiology ranked like 14th out of some of the most popular specialties, which is pretty bad. And then you look at underrepresented in medicine, ranked 20th in radiology, right? And when you look at the numbers percentage-wise, right, about 50% of this country female, you see in medical school, it's actually pretty close to 50% female medical students, but then you see almost half of the representation in radiology, and then that representation goes down as you move up higher in the ranks to faculty and leadership positions, chair positions, right? URM, similarly, when you look at black medical students, they probably make up around 6 to 8%,
Yeah.
which is about half compared to 13% in the United States. And we see similar trends in radiology. That number is still very low, and it continues to stay low as you move up in the ranks. Same for Hispanics. So you're seeing female medical students really not being well represented in radiology.
Yeah.
And there's an emphasis now, and I think a huge catalyst was the murder of George Floyd, which basically made a lot of people in medicine realize structural racism in this country. And a lot of programs are kind of emphasizing that we need to do something about it, and having a number of diversity, equity, and inclusion, DEI initiatives to help counteract those issues with race that we have in this country. As far as solutions, right, I think it really has to start with understanding the value that diversity has on all of us. This isn't something that just benefits Black medical students or a specific demographic. This ultimately helps all of us in the long run. So what do I mean by that? There's studies that have shown more diverse organizations are better when it comes to problem solving. They're more innovative, right? Now, if we look at medical school and how diversity can help there, right? We're seeing that more diverse student populations, they tend to have better interactions with patients from underserved communities. It helps sort of expand their perspectives, and this sort of cultural competency that's been emphasized in medical school, that is sort of a reasonable approach, right? And it makes sense. If you've got a diverse student body, they're going to interact and they're going to be exposed to these different perspectives, ideals, cultural values, and that in turn, when they interact with each other, will transmit to the interaction with patients from different backgrounds, right? So we all have to sort of have buy-in that diversity has tremendous value. Patient satisfaction actually is better with a more diverse medical team. So once we sort of have that ingrained in medical education, then I think a lot of these initiatives they'll have more participation from people, and I think it'll be a better thing when it comes to recruitment.
I'm just curious, did you ever look into the reasons why radiology is doing so poorly in terms of representation of women and folks of color? Is it because radiology has been overrepresented by, the classical white male physician? Is that the primary dissuading cause, or are there other sort of external factors that either has been researched and published on that you may have read upon?
Well, I'll first touch on my own personal experience.
Yeah.
And when you're looking at different specialties, and you don't see people who look like you, it can be very discouraging trying to see yourself in that specialty, right? Fortunately for me, I actually went to a program where there was a Black radiologist, but not a lot of people have that opportunity, right? And when I was interviewing at many radiology programs in this country, it was very, very hard to find people who were Black at any level, not just like residency level, but in the radiology leadership, faculty members, and so on. I think there's multiple factors, right? And one of the biggest factors is exposure. Radiology is one of those specialties where not a lot of people get exposed early on in medical school. So if you don't have that exposure, then you're even going to be more unlikely to not choose that path, right? On top of the lack of exposure, I think we are we have to acknowledge that it's an uphill battle because a lot of people already enter medical school with an idea of the doctor they want to be, right? And for me, for example, I actually wanted to be a primary care provider, and that was my idea of what a doctor was. So I wanted to talk to patients every day. I wanted to make meaningful medical decisions for them. And a lot of people have that idea, right? Radiology is not a specialty where a lot of that is really the foundation. It is sort of interesting because, man, radiology now is amazing, right?
Yeah.
When you're actually in it, like who could say no to this specialty? Because it has so much to offer when it comes to work-life balance, when it comes to compensation, and so many things. But you're seeing that women, female medical students, when they don't choose radiology, it's because of the length of time that it takes. It takes at least 5 years, right? Compared to primary care specialties where it may only take 3 years. You're seeing female medical students who do choose radiology, they're more cognizant of work-life balance, more receptive to that, and the time to commit to the family, as well as compensation. So we have to understand that different demographics are going to have unique needs, and radiology has to do a better job with really rebranding itself to those groups, right? For Black medical students and minority medical students, they tend to have more emphasis on giving back to their communities, right? Well, how are you going to do that sitting behind a desk reading scans all day, right? So rebranding and emphasizing that radiologists actually do tremendous work with population health, right? You may not have meaningful interactions with patients on a daily basis, but when it comes to breast cancer screening, lung cancer screening, we're seeing radiologists play a really significant role in guidelines, in community outreach. Something that we're doing here at Penn is trying to have more emphasis on community outreach and get people from underserved communities more accessible to the resources, to the screening resources. So we have to really understand each group sort of has its own different needs, that many medical students lack exposure, that many medical students also have misconceptions about radiology, and the diversity of radiology in terms of the workforce, right? Like you don't just have to sit behind a computer screen all day and dictate yourself to death, right? You can actually do interventional radiology, interact with patients constantly on an inpatient and even outpatient basis. You can do breast imaging where you're actually doing the ultrasound, talking to the patient, providing comfort, empathy, giving difficult talks and difficult conversations when it comes to conveying the diagnosis of breast cancer, right? And then the procedural aspect of doing the biopsies. You're seeing some procedural aspects in musculoskeletal radiology when it comes to chronic pain management. So all of these things should be incorporated into the message, the brand of radiology. And I think if you do that, that more people from these underrepresented groups will be receptive to a career in radiology.
Yeah, I think that the rebranding part is especially key here, right? Because it's almost forbidden to talk about work-life balance, even though that's probably at the forefront of a lot of majority of the medical students who are coming out and joining the residency workforce, right? Mm-hmm. And not only does radiology offer work-life balance, it also offers, as you mentioned, the ability to interact with patients. And what is unique about radiology is you can actually control how much you want to interact with patients, right? You can totally be the radiologist sitting behind a desk dictating, or you can be completely patient-facing, do IR, do mammography, right? Or even MSK, where you can sort of dictate how much you want to interact with patients. Same with neuroradiology with some of the spine procedures, head and neck procedures, injections, right? So tons of flexibility there.
And even outside of the clinical context, you're seeing more radiology leaders in health services. You're seeing more radiologists getting involved with artificial intelligence.
Right.
And that has a connection to clinical, but you're seeing radiology as a career can really branch off to a lot of different avenues professionally. You don't just have to be kind of stuck in a clinical mindset.
That's right. And the fact that we have the work-life balance allows us to dabble in a lot of these things, right? So it's definitely not far-fetched to be a radiologist as well as have like quote-unquote a side gig, right? A lot of the folks, and it's common among podcasts too. A lot of radiologists end up doing that. But you know, it's a great field. And as you said, there's a huge branding issue. Medical students are not getting exposed. Even when they're getting exposed, they're only looking at it from a very superficial lens provided by other specialties, right? They say, oh, AI is going to take over radiology. Oh, you're going to be in a dark room all day. Oh, it's 5 years of residency. Why bother, right? And we just have to do a better job. And now one of the ways you're doing a really good job is sort of disseminating the positivity of radiology as well as lots of mentorship on Twitter and social media, right? I think in the end, I want to touch upon this. I think from when we started applying to residency, there has been, at least what I felt like, you know, a big explosion of medical students and residents getting kind of more and more involved in social media. You know, gone are the days where you have to delete all your social media, hide it from the residency programs. Now we're sort of seeing, yes, you'll still delete all the embarrassing stuff, but you put forward this profile, like almost this professional profile, pseudo LinkedIn on Twitter. You introduce yourself, you try to connect with people, try to sort of form mentor-mentee relationships with folks from around the country, right? And I feel like, at least to me, it positively increases the exposure that you may have to, you know, radiologists of color, right? In your mind, like, you know, I think we can both agree, like, it's important, but in your mind, is it almost becoming essential for medical students? And if so, how should they best take advantage of it going forward?
I think social media it can be a very powerful tool when it comes to networking, right? And not everybody really talks about this. And I can remember when I was applying to residency, I thought you get all your application materials together, submit it, and then you just wait, right?
Yeah.
But networking is always happening behind the scenes in any industry, right? Yeah. Networking is one of the keys to getting the right job, to meeting people, and getting connections. Social media can be used that way, and we're seeing it being used in both ways, where programs are able to advertise their initiatives. I saw plenty of DEI initiatives, whether it be open houses or sort of like these virtual happy hours for people to connect and interact with each other. And you're seeing medical students create social media accounts to get their faces out there, to express their own values. I think as long as you keep it professional, it's probably not going to hurt you, right? Yeah. But every tool sort of has its razor edge, right? Yeah. And something that could be used for good can be easily used for bad. Mm-hmm. And what I've seen in social media, which at times can be very, very toxic, right? Yeah. When you look at diversity across programs and sort of try to either like call out programs based off their lack of diversity without really understanding the underlying process of how they select candidates. I think I've seen other people have anti-DEI opinions about that, and people everyone has an opinion on everything, right?
Yeah,
and
yeah.
You really see it on social media. Something that was really unfortunate that I've seen is, a lot of people, when they see people of color, when they see female medical students matching at programs, there's always this twist that it's sort of they got in because of their sex or because of their racial ethnic group, right? That it's sort of a huge benefit for them when there's many qualified candidates, and that gets overlooked, right? And so you can imagine the effect, right? If you're a minority female, you're excited about matching and you're reading comments on social media about how you got your foot in the door, not because of what you earned or your qualifications, but the perception that, oh, you just got in because they need the token black resident, or they needed to have at least one female resident in their program. And that could be have a huge negative impact on that individual, right? Because that really plays into self-doubt, right? When you are hearing these things about, oh, it's not my qualifications, it's something else, and that plays into imposter syndrome and all these things, right? So I hope that programs, leadership, when they do see these things, they're able to reach out to the residents who match and just offer their support, either on social media. I think publicly is probably a good way to approach it, but also privately, right? Like, you're here because we looked for the best candidates, and we understand the value that a diverse working team has to offer. But that does not overplay, or that does not downplay your CV, your resume, your accomplishments, right? So I think we have to try and support residents in that sense. Now, what does a program do when they don't have the diversity, right? I see this a lot, and many of them feel like their hands are tied, right? Because, of course, the programs that have the most diversity, it's super easy when it comes to advertisement marketing, right? It becomes that much easier to advertise, and people want to be diverse, underrepresented people want to be in a program where they're not the only one, where there's other people, right? So I think I've seen some data that suggests this, but that sort of disproportionately puts female underrepresented minority students more towards the programs that have the resources and the diversity within their programs, which really leaves the other programs kind of in the dark. And, what could they do? I think one of the most important things is understanding the values of the people you're trying to recruit, right? And for myself, I often, as I mentioned, was one of few black faces in classrooms at different institutions, which also meant I had a lot of mentors who didn't look like me, right? So it's not just about trying to find the mentors who look like you. I think there's plenty of minorities and female applicants who can see value by going to people who are just able to be receptive to the values that they have, right? Whether you look like them or don't look like them probably doesn't matter that much. It's a nice bonus if it does align that way, but it doesn't have to be something that inhibits that mentorship relationship, right? I've had plenty of mentors who didn't look like me, and they contributed immensely to my success, right? So this formula does work, right? And even in one study, when I looked at radiology residents, they actually preferred male mentors because they had more resources, right? They tend to be people who are at higher top in the leadership to begin with. So it kind of works in more ways than one. But the bottom line is you have to connect and understand the values of the people you're trying to recruit. And if that is the first thing that people notice, I think that's a powerful message, and at least will work better than I think a lot of people give it credit for, right? When it comes to DEI initiatives, oftentimes it's like about having the black person lead the initiative, right?
Yeah.
Because that aesthetically, that's how we want it to look. That's how we feel it has to look. But it doesn't mean that we force them to take on that position.
Right.
And it doesn't always mean that someone in the majority can't take on that position and offer some value to trainees when it comes to giving them exposure to DEI ideas and values.
So you talked a lot about mentorship, and I think what's very prominent and evident is the fact that you continue to be a mentor for medical students even now, right? And I think the best part about that is we all have busy lives. Residency. Your wife's a resident as well, but that aspect of giving back, it doesn't have to just start when you're attending, right? And looking back to like an undergrad who's thinking about going to medical school, but it's kind of along the entire way. And there's different kinds of insights that you can bring in as you build that up. And I think, it's really, kind of like something to aspire to. And I think, even for this podcast, like part of the inspiration was in a similar kind of vein of, in our way, giving back this information that we've either learned in the past or learning in real time. Because, I think it's that sharing of resources in a very kind of open, scalable way that hopefully more people can benefit from it. Hopefully they benefit from this conversation. And then, more people are equipped with either the knowledge or the tools to be in a position to make these kind of changes going forward. Because ultimately, I think they keep saying, we're the future, or at this point, the generation behind us is the future. But, like change is happening. It just takes a while, and maybe it takes a generation. But I think it starts with mentors. We've had mentors that we can continue to be, and continuing this conversation.
And mentorship that can take whatever form that the person's willing to pursue and invest in, right? If it's going on social media and being a presence, and that's nothing more than that, that has an impact, right? If it's reaching out to undergrad students, medical students, that works too, right? I think an approach that I found useful from medical school, and something that people may consider, particularly programs, residency programs, is the value of vertical mentorship, where someone is able to see the next step in front of them in their professional development, but then also have someone a step behind them to give support, right? So in residency, it would be a resident who has an attending as a mentor, right? But then also is able to give back and be a mentor for someone in medical school. And then that medical student could be a mentor for someone in undergrad, right? That's something that I think works very, very well, because the hardest thing is to really see the next level, the next stages in front of you, right? Can you imagine when we were an undergrad, right? Like, I maybe knew a couple medical students, but how much easier is the path to be a physician when you are able to recognize, okay, that's the next step, and then I could see the next step after that, and you're able to kind of understand the different demands, the different stages of someone's professional career.
Absolutely, man. I think that's a really great idea, and a very poignant one too. Because you're right, I didn't know a single medical student in undergrad. I mean, I knew physicians I was doing research for. Actually, no, that's a lie. Now that I think about it, I did come across medical students in the research lab, but purely from like a research context.
Yeah, like a more in a professional
That's
setting,
right, yeah. But it was never in a context of you're applying to medical school, let's sit down and let's talk.
Right.
And let me mentor you through this entire extensive process. That is brilliant, man. And I feel like, with social media, that has brought a lot of us sort of closer, at least in the virtual space, where this can be more possible, where you don't need to be even in the same medical school, let's say.
Exactly.
Yeah.
I talked about this earlier, be proactive.
Yeah.
Not everything is going to come to you and fall in the right places. Sometimes you just have to go out there and initiate, And I did that a lot when I was applying to residency, and it worked out.
Yeah,
I would
no.
say so.
Yeah.
Never forget the power of being proactive.
Well, Damien, thank you so much, man. This was very, very eye-opening. It was very interesting to, first of all, get your background and really learn about all the stuff that you've done before medical school, stuff that you've done during medical school, and stuff that continue to do in residency to like inspire a very diverse future generation of physicians. Thank you, Damien. And thank you to our listeners. Thank you so much for logging in and catching another episode of Clinically Correlate with Azfar and Vedant.
Had a blast.
Had a blast. No, we
Can't
did.
wait for the next invite.